Thank you very much, sir. It's always a pleasure to come back to my alma mater. And thanks, Dr. Deeman and Deepak, dear Amit, to give me the opportunity to speak on this topic. So next 17-18 minutes, I'll be telling you about the management of E-negative acute chronic hepatitis B infection. This is the outline of my talk. Hepatitis B virus once enters into the body through the parenteral routes, being it's a heterotrophic virus, goes to the liver, and inside the liver it starts its machinery and starts synthesizing its particles, and immediately the blood is flooded with the lot of viruses in the blood. So the first phase of infection starts, which is a chronic infection, where there is a lot of virus in the circulation, but there is little immune response. This phase can last for many years, depending upon the age of acquisition of infection. Then when the immune response is active against the virus, the immune system starts clearing the hepatocytes laden with the virus, and there's a phase of chronic hepatitis starts. And once this starts, the virus starts getting destroyed by the host immune response. The virus is clever enough to lose its E antigen, so that it can hide from the immune response of the body. And the virus goes into a phase of E negativity. He loses E antigen, and again he goes into a phase of E negative virus. Like it remains stable, but the viremia level in E negative state is relatively lower than that of E positive state. Once in E negative state, and there is no inflammation going on, it is chronic infection. But in between, there is resurgence of immune response against the virus, and the person develops chronic hepatitis. So today we'll stick our discussion on to this E negative phase of chronic infection. Since E negative phase occurs at the later stage, so the patients who are infected with E negative chronic hepatitis B virus are relatively older compared to those who have E positive infection. The clinical presentation, most of the time they are asymptomatic, they are diagnosed incidentally, but sometimes they are diagnosed when they develop cirrhosis and its complications. How do you treat them? What are the indications of therapy? Depending upon the societies, ASLD says if your AST, ALT levels are high, if the virus level is more than 2000, you treat them. Whereas EGL says your virus level is high, ALT either normal or above the normal, but if the liver has got moderate to severe inflammation, necroinflammation or fibrosis, then treat. Whereas APALSA says virus level is high, ALT is high, you treat, but even if your virus levels are low and the ALT level is high, but if the underlying liver shows moderate to severe inflammation and fibrosis, then you treat. Our own INSL guideline says in a non-cirrhotic person, high ALT, high DNA, you treat. High ALT, low DNA, you just follow them up. But low ALT but high DNA, again you treat. Whereas a low ALT and low DNA, you just wait and watch, observe them. In between 2000 to 20,000, you just go for the markers of non-invasive markers for evidence of chronic liver disease. If there is significant fibrosis inflammation present, then only you treat. What do you treat them with? The therapeutic options currently available with us are targeted against the hepatitis B virus level based on the landmark REVEAL study, where most of the patients were E negative, and it shows that it is the baseline viral DNA which determine the ultimate course of the disease. So higher the DNA, higher the risk of cirrhosis, higher the DNA, higher the risk of SCC. So if you target the HBV DNA, bring it lower down, you can reduce the inflammation in the liver, you can reduce the ALT level, and so that you can prevent the occurrence of cirrhosis, carcinoma, and ultimately the mortality. The options available with us are pegylated interferon and the nucleoside analogs. We all know nucleoside analogs currently available with us are entecavir, tenofovir. They are high potency, high genetic variant to resistance, and they are used in most of the cases in our practice. PEG interferon, although available, is less used because of its side effects. The available therapies, they act at two levels. PEG interferon stimulate the immune system against the virus, so they kill the virus-laden hepatocytes, whereas the nukes, they act at the intermediary step in the synthesis of viral particles, that is the reverse transcriptase site, and it inhibits the replication of the virus. It doesn't kill the virus, reduce the replication of the virus, whereas PEG interferon will kill the virus-laden hepatocytes. The advantage of PEG interferon is it can be given for a shorter period, a limited period, 1 year. It has got a high seroconversion rate, and And it has got an immunomodulatory antiviral properties, so that even if you stop the drug, it becomes very effective, even if you stop the drug. Whereas the disadvantage can be injectable and a lot of side effects and the poor tolerance by the patients. What we use commonly in our practice is nukes. These are the doses. How do you choose the nukes? In adults, you can choose anything between tenofovir or entecavir, but entecavir is preferred in children. TAF is given in person with renal dysfunction or bone disease. The earlier generation nukes are out of choice now. And again, you prefer entecavir over TAF, over TDF in patients who are elderly, bone disease or renal abnormalities. And you prefer TAF over entecavir in patients who have a previous nucleoside exposure or a co-infection with HIV. And one is entecavir is preferred in a person who has got advanced renal disease. So what is the efficacy of currently available drugs in E negative? Look at the PEG interferon, DNA suppression, very little, but with nukes, more than 90% of people, they achieve the DNA suppression. But look at what is the HBV loss, very little, only 1, 0, and but slightly better with PEG. So HBsAg seroclearance, slightly better with E positive, but when we talk about E negative, it is very less, slightly better in PEG interferon, but it depends upon which genotype you are dealing with. So HBV seroclearance with PEG depends upon the genotype, whereas with nukes, it has got a very little effect. So what are the stopping rule for these therapies? ACLD guidelines says you don't stop, keep on giving them till the life. Whereas EGL guidelines says you can stop after 3 years of virologic suppression. But Apostle says you can still stop after 2 years, but there should be 3 readings of negative DNA 6 months apart in a person who is not serotic. What are the problems with the current therapy? The goal of HBsAg loss is rarely achieved. They fail to suppress the viral replication and they fail to prevent disease DNA establishments. So what do you aim for when you are treating HBV? What is your aim? Your first aim is to reduce the viral DNA. Then second aim is to seroconvert in a person who is E positive. Then you want to make the DNA undetectable. Then another next milestone is you want to lose the S antigen. And then next is you want to the cccDNA to be cleared. Accordingly, the HBV cure can be partial, functional, or complete. A partial means DNA is negative, but HBsAg is less, but still present. Functional cure means you are losing S antigen, but the cccDNA or the integrated virus still present. So far, we want to achieve functional cure in all of our patients, but we can dream of complete cure and sterilizing cure for a better treatment. But you want to go for a functional cure because you can stop the nuke therapy, you can stop the antiviral therapy, and less monitoring is required, and these patients will have an improved quality of life. What are the strategies to improve the functional cure with the available drugs? There are various strategies. I will discuss first 3 and the rest. I think my next speaker will tell you. So what about the stopping the nuke therapy? Is there why do you want to stop nuke therapy? Because the concept is with a low level of HBV replication, if you stop the nucleic acid therapy, nucleotide therapy, then there is a resurgence of HBV DNA that act as a auto-vaccination, and there is an activation of immune response against this virus, and the immune response probably start clearing the virus. Is there the currently available therapy functional cure is very little, as we have already discussed. What is the evidence? If you give nukes for finite or infinite, whether the clearance is better or not, but there is evidence available with finite therapy, HBsAg loss is much better than those with infinite therapy. So the study is available. I think the first study in E negative is this one, very less number of patients, but in 42% of the patients, they achieved the HBsAg loss. Randomized control trials, this German study was predominantly in all of them are E negative patients, 158 patients, and around 10% they lost the S antigen over the period of 96 weeks. What are the determinants or the predictors of response to S clearance? A sustained virological response, very high rate of clearance. A virological relapse, the rate is less. But if there is a relapse and they require no treatment, then again a better loss. But a relapse requiring retreatment, the loss is very little. So Another a finite study, randomized control trial, but a very small number of patients achieved 19% as loss. I think this is the latest study, and this is the final, the bottom line, the DTRACT study, large global multi-center, multi-ethnic cohort study across Asia, Europe, and North America, 15,000 odd patients, 1,500 odd patients, and this is the bottom line. The probability of HBsAg loss at 48 weeks is from 3.2 to 13%. And which category of people? People who are virally suppressed, E negative, who stop nuke therapy, if it is a white, S antigen level less than 1,000, very high risk of, a very high chance of HBsAg loss, to stop nuke therapy. In Asian patients, the level is less than 100, and then you stop. In rest, you probably continue. In the same study, the loss is better with increasing age, better with tenofovir, and a previous long-term nuke therapy or previous interferon therapy also helpful in losing the S antigen. But look at this. Moment you stop the nuke therapy, the virological relapse occurs in almost all at 48 months, whereas around 50% of patients, they require the retreatment. So what happens when you stop? There are three phases. When you stop the treatment, there is a lag phase. After lag phase, there is a reactivation of the virus. Viral DNA comes back. Viral flare occurs in almost all. Well, the ALT flare also occurs in some, but most of the time it is tolerated. And then there is a consolidation phase when the immune system decides whether it will be able to clear the S antigen or not, or the HBsAg loss occurs in somewhere around 20% of patients over the 2 to 3 years of follow-up. When you stop the nukes, you have to follow them very closely, very minutely to look for the recurrence of the viral flare or the ALT flare. And these are the retreatment criteria which are used based on bilirubin levels, PT levels, as well as the ALT levels. Whenever there is a recurrence or to decide retreat, you need to differentiate between the two types of flare. One is host-dominating flare, where the ALT is high, but the S antigen and DNA are in declining phase. This is the people who do not require retreatment with antiviral agents. Whereas a virus-dominating flare, where the ALT is high, but at the same time S antigen and DNA are also increasing, these people, they may rapidly deteriorate to decompensation or mortality. So they require a restart of antiviral therapy. Can we decide any other way? There are other ways because when the DNA is high, the T cells are exhausted. When you give nuke therapy, DNA level goes down. But if these T cells, they remain still exhausted, there is no immune activation of T cells, then don't stop. Okay, how do you know whether the T cells are still exhausted or not? This can be known by various biological markers. Other than my next speaker will tell you. But if on nukes therapy by reduction of HBV DNA, if the T cells become activated, this is shown by the reduction of HB S antigen levels. Then when you stop nuke therapy, probably the person is more likely to lose the S antigen. So what is the bottom line? If he has liver cirrhosis, don't stop. If his DNA suppression not achievable, not possible, don't stop. HB S antigen less than 1,000, you can try stopping them if the person agrees for a close follow-up over the period of next 1 to 2 years. Next, can you add interferon to nuke therapy after DNA suppression? Yes, there are three possibilities. You give nukes alone, or you give nukes in combination with interferon, or you give interferon alone, or you initially give nukes, suppress the virus DNA, and then you switch to interferon. The interferon and nuke addition, because those both have got different mechanism of action, and the adding interferon to nuke will be complementary, and stimulating the immune system will kill the virus better. So the options are, you give either a de novo combination. The de novo combination little better response compared to the monotherapy with interferon, but the best is you give nuke in HBV suppressed patient and then you switch to PEG interferon. The response of HBsAg loss is much better when you switch therapy. Okay, so this is a meta-analysis, systematic review, saying the same thing which I told you just now. And this is the largest data of Chinese study, around 3,000 old patients. Add-on or switch to PEG interferon, 48 to 96 weeks follow-up, and analysis was performed after 48 weeks. So 66.6% lost the S antigen in those who have got very low DNA level and the S antigen level. So functional cure is possible in nuke surface patient by using the PEG interferon. What are the novel antivirus and novel immunomodulatory combination available? I'll just slide show a few of these because it's not part of my talk. There are various target sites available for the newer therapies. These could be categorized into various headings like nucleotide analogs, entry inhibitors, capsid assembly modulators, translation inhibitors, and the secretion inhibitors like the NAPs, nucleic acid polymers. The entry inhibitor stop the entry of virus into the cell. Capsid assembly and disassembly both can be taken care of, or they can be core inhibitors where they inhibit the cccDNA, or there could be antisense oligonucleotides or siRNA. And then the nucleic acid polymers inhibiting the secretion of the virus. I'll just skip through. And there are other approaches, could be immunomodulatory therapies, because direct acting antivirals and agents will reduce the replication of the virus, but they won't be able to kill the virus because the cccDNA is persisting and the virus remains integrated into the host DNA. So it is the immune system which will target the integrated virus and remove the virus-laden hepatocytes. This immune modulation can be by modulating the adaptive immunity or innate immunity, and they can restore the T cell activation. They induce the innate response, or there are various therapeutic vaccination and T cell transfer therapies available. So what is the bottom line? Bottom line is you need a combination. Combination first, you reduce the replication of the virus by either nukes or by entry inhibitors. Second, you reduce the cccDNA, the production of S antigen, by giving either NAP or antisense or the RNA. And once both of them are DNA is reduced, S antigen is reduced, then you give the immune stimulating compounds which will kill the virus, which is virus-laden hepatocytes, which are available in very less number. So which therapy will work? What is the combination? What is the sequence? We still don't know. Till then, stop nukes after 4 years of treatment when the E negative S loss better with whites. In Asian, the target is S antigen less than 100, then you stop. Patient with low HBsAg levels, several years of DNA suppression, a switch to interferon might improve the S loss. Interferon alone, highly selective. New targets are available. They were still in trial. Combination therapy would most likely to be needed in the future. Tailored therapy, I think, will depend upon the HBV biomarkers. One size doesn't fit all, as is true with all other disorders. Till then, we should be happy with partial cure, which is the, I think, current state of our problem. So the person remains DNA suppressed and the S antigen level low, and then you keep on giving them nukes till then. Thank you very much.